Okay. Again, I'm Dr. Carrie Tran. I'm a general dentist, and I've been with Healthier Kids Foundation probably from its infancy for the dental program. So it's good to see the amazing work that we do. We transform lives, and I don't want to understate the good work that all of us in HKF has done. So I'll just get to the meat of the presentation, which is the dentist calibration training. And when I started, this is our first training ever. And so when we started, it was just basically this screening form here. But very, it was just the skeleton of it. So I'm really glad that we're actually going through point by point on the screening form.
Can everybody hear Dr. Tran?
So the goals today is going to be, like I said, the meat of it is going to be the clinical guidelines, and we're going to reiterate that this is not a criteria. They're guidelines for us to follow, but of course we are all licensed dentists with our own malpractice, so we work independently as contractors. So just take it, of course, with a grain of salt. So the screening form we're going to go over, then we're going to do the no follow-up versus follow-up from case managers and what that means in regards to the form. And then we'll touch on, there's a new sealant data that we need to collect for public health. Okay, so here, just wanted to show go over the screening form itself. The history is that there was no app when we started. It was just a basic hard copy form like this that we would go to every screening with, and it looked basically the same as it does now, except that we had there's more categories, there's more subcategories. We added this awesome adult odontogram. There's a signature down there that used to be a stamp, but now it's virtual. And then over here, I love this because that is, it talks about, the effectiveness of sealants and fluoride varnish. And then what we don't see on the hard paper is the comments box. So that's also new. Okay, so the advantage of this, obviously, now that it's basically our communication tool with the parents and the dentists. Because it's virtual, because everything is on the app now. We get things more instantly. We're able to collect the data. We're able to upload and then also analyze the data more efficiently. The limitations, it's going to be that what Kathleen touched on is the screening form cannot be changed, unfortunately. Even if we wanted to change, add a subcategory or do something, different to it, it's pretty much not right now. So we just have to work with what we have. Okay, so on the left side, that's the dental screening app that we're all used to during our screenings. And then what happens is once we diagnose, or not diagnose, I want to say that, once we categorize the child, they get a printout at the end of our screening, and then it only prints out what the child, what the results of the child is for that day. And so you're not going to get all the gum disease and soft tissue. It's just basically what we found on the child. And also the odontogram, whatever we circled on there, is going to be transferred onto the printout for the parents or the guardian. Okay, and then the all-important, the comments box here, we're going to touch on, because this screening form is, we're not able to change it, everything that goes into that comments box is very important. And so I kind of want to highlight that throughout this meeting. Okay. Let's see. Sorry, and just to touch on the comments, so the comments box is going to be transferred here. It doesn't have anything because nothing was written. These are two different children that were screened, but basically for the comments box, that's the communication tool that what I've found, what we've talked about with case managers is that they really want us to use dental terminology. And one that kind of gives the screening form more weight. It's a form that we encourage the dentist, the child's dentist to review. And so it gives it, it gives motivation for the parent to actually get the kids an appointment with their dentist and to show them, this is from the dentist that screened them. So that's pretty important. Okay, so basically the form that you have is going to break up into two sections. There's the follow-up is on the bottom. The top is 0 and 1. That's this part here, and there's no follow-up with the case managers there. Basically, they don't get a phone call. It's just routine, anything that, if you found that, just basically everything here, which I'll go over. And then the second part is going to be the follow-up, where the case managers will be calling the guardians within a certain amount of time, depending on where we place the child here.
So does everybody already know that the 0 and 1, the parent will still get the form, but the case, we can only do so much, so the case managers only follow up on the 2s and 3s.
Yeah,
So
exactly.
makes sense to everyone.
And we'll go over that too. Yeah, so this is what Kathleen was saying. So for the routine, which is 0 and 1, there's no follow-up. And then with the urgent, which is the 2, they'll have a follow-up within 2 weeks. That's the aim. That's the goal. With the emergency, that's going to be less than 1 week. And then there's a special one where it's called escalation, where that's immediate. So Kathleen will be CC'd, Sunny, and that case will be escalated. Okay. Okay, so we know this. 0 and 1 is going to be no follow-up. Okay, so this is 1, which is the routine dental care recommended. So basically, it's straightforward, 1A through 1D. I would say, dental clean recommended if there's light or moderate plaque. Of course, that's like a continuum, right? And then screen for cavities between the teeth. If you see, just slight white spots that are maybe a little bit suspicious, but they're not cavitated, I would put that as screen for cavities between the teeth, if it's suspicious. And then the sealants, we're going to recommend it for first and second permanent molars only. We're not going to recommend it for premolars. And then, this is stained teeth. If you see any stained teeth, with no cavitations, it's going to also be in this category. So 1A through 1D is pretty straightforward. If we'll touch on 1E with Dr. C, but basically, if you see a child that's here, or if you see a child from 1A for 1D and you think, they don't fit in any of that. They're really clean. They stated to me that, hey, I just had a dental cleaning maybe like last month. Then I would just put them in 0 if you don't see anything for them. And that's a special category. I think Kathleen, you said that you wanted for the no cleaning or no follow-up.
That's our goal.
Yeah, that is our goal.
Not goal, I guess. It's our vision is that every child would get a 0.
It was 0, of course. Okay, so we'll touch on 1E in just a second. And I'll cover the caries part. I'm going to do that with, urgent and emergent. So for caries, mild and moderate is going to be 2A, and then severe cavities going to be under 3C. So we're going to categorize caries. We're going to evaluate it based on the depth and not the number of, based on the depth, and then we're going to evaluate number of surfaces involved. It's not based on number of teeth involved. So these are, like I said, these are guidelines. It's our disclaimer that use your professional discretion when you are looking at the child and doing the screening. We realize that this is a visual exam, and it is not considered a dental examination. Okay, so the difference between 2A and 3C. So this is pretty straightforward. It's going to be considered gross caries, and under 3C. And, basically, you want to evaluate the depth of the caries. Does it, does it look like there's pulpal involvement, or is it encroaching upon the pulp? Then if you say yes, it's automatically 3C. Mild and moderate caries, even if they have, 10 teeth that have class 1 caries and it's barely into the dentin, that's still considered 2A. Does that make sense? Okay. So for 2A, for the comments box section, we're going to write, we don't have to write any notes. We just have to circle the tooth or the teeth on the odontogram. But for 3C, you always have to have a comment in there regarding the gross caries, where it is, and then it goes to this part, which is if you have both gross caries or severe cavities, and you have like a mild or a moderate cavities, you're gonna want to put them in the comments box and distinguish which teeth have which type of caries. Okay, and we really want to emphasize to put in the comments box to have the child scheduled for a dentist appointment right away. That's a message to the guardian or the parents, and it signals to them that dentist, is recommending this for your child. Okay, so it's important. Okay.
Okay, great. Thank you very much. Thank you. All right, so just wanted to recap a few things. Does everyone understand why we're here today? Right, so we're here because we want to tighten up the variability from one provider to the next provider, and the dentists that are as you are doing the screening, we're seeing children. Each provider is seeing children over 1,000, and so when you have one that is recommending 15% as emergency versus those that are recommending 35% as emergency, that's a fairly large variability, and the idea is to tighten it. So it's not to say that the average should be 32% or the average should be 35%. That's not why we're here. We're rather trying to streamline what the thought process is for why we're doing what we're doing. Continuing forward, a lot of what went into developing this training was a basic understanding that whenever a child is placed into 0-1 or routine, there will be no follow-up by a case manager. Rather, if a child has an urgent or an emergent condition, there will be a follow-up within 2 weeks to 1 week, respectively. So moving forward with this concept, as what's already listed for 2B, under gum disease, whenever we see something like moderate to heavy plaque or moderate to heavy gingival inflammation, it's important to circle the soft tissues on the odontogram that's been discussed, that's been shown previously. And then it's not necessary, as far as 2B is concerned, to include anything under the comments box. And it's not to say that you shouldn't put anything there. It's just it's not necessary to place it there. The reason why we're making the emphasis on writing things into the comment box is because what's placed in the comment box will be used by the care coordinators and the case managers to then educate the parents on the necessity, and then that would kind of close the loop in terms of following up with the patient's or the child's dental care. So the next one that we have is any time that we see a soft tissue lesion moving down the form that we have in front of you as 2C. And what we see here is in this particular case, it is recommended to state in the comments box, and specifically the number, color, and shape, and to draw the lesion on the odontogram. And so I know this is a little bit of a grainy film, but what we do have here is that there's lots of these little spots that we have here, or as what's described in the comment box with this particular image, that there's approximately 25 millimeter red and white round lesions on the right side of the child's cheek, and please have a dentist evaluate. So again, something like this, the parent will be contacted within about 2 weeks in order to inform the parent or the guardian that the child should be seen with a dentist. And the fact that this is placed right here, this is something that's easier for the parent to connect with in terms of what's going on, and also then to follow up with the child's care moving forward. So again, just to recap here, with what's placed in the comment box, anytime we have a soft tissue lesion, please write the number, the color, and the shape in order to then better educate those that will touch the form. Next up, we have recent trauma, which is 2D. Similarly to soft tissue lesion, we're recommending that we write something into the comment box. And what's utilized in this particular case is the chief concern, the history, and the objective finding, and then the dentist to draw the trauma site on the odontogram. So in this particular instance, we have a discolored tooth number E. A child might say that he fell and hit his front tooth, doesn't remember when. Number E appears dark. Then there's no soft tissue trauma detected. And of course, if there was in this particular case, then it would be documented as such on the screening form, and then the recommendation to follow up with the parent and with the dentist. Okay?
And NOC plans to send this out to everybody.
Okay,
And
great.
I'll also provide a link to the video of the movie.
Okay. Okay, great. Thank you. So now we kind of come across what's labeled as ectopic eruption in 2E, or orthodontic work recommended for 1E. And the distinction here is that whenever something is placed in 1, there's no follow-up by a case manager. Whatever's placed in 2, there is a follow-up with a case manager. So before we get into the other examples that are going to be recommended for 2E, it's really important that you focus on what your professional discretion would be. Understanding that 1E has no follow-up, so anything that requires an evaluation by a dentist or a follow-up with a dentist, albeit let's say that there's an extracted a number 19, right, and the child is already 7 years old. So that is something that is on the borderline, which should err on the side of a follow-up at a minimum, not no follow-up. And so moving forward with this concept into different examples, things that would be maybe considered for necessary orthodontic intervention, regardless of the age, whether the child is 6 or even 4 in some cases, if they're a thumb sucker, or as old as 14 or 15, things that we would at least at a minimum recommend a follow-up with a dentist would be open bite, anterior crossbite, posterior crossbite, deep impinging overbite, severe overjet, and then beyond that, significant ectopic eruption, cleft or lip palate, anything that may impede the airway, and then severe crowding. But really fundamentally, of all these different things that are being just kind of labeled here, you know, like an A to Z or kind of like a checklist, really it's important to use your professional discretion about it. Okay, if the severity is enough or significant enough, then, and it requires a follow-up with the dentist, then it should be recommended as such to communicate with a case manager. And similarly, with the other stuff that has been discussed, to place a note in the comment box. What is it that you're doing and that's recommending for a case manager to follow up with the parent or a guardian to see the dentist?
But Manu, so you're saying if it requires orthodontal work, that would be a 1, correct? Because we don't really get into the orthodontal efforts. If it's something that was severe and needed a dentist or a surgeon or something like that, then it would be in the 2 section, right? Because we've had trouble where it's, you know, an orthodontist kind of issue, and because it doesn't really fit into Medicaid very well, Medi-Cal, we can't, I mean, we had one school where 50% of the kids needed an orthodontist, and we really have no ability to help there. correct?
So I understand what you're saying. At the same time, as a clinician, it's important that if we see something that is severe, is significant, and would be best for some kind of follow-up. So of course, if it's mild crowding, or if there is mild displacement, mild ectopic eruption, then those are which doesn't require a dentist to follow up. So as dentist screeners, none of us are orthodontists to say that it should be this or it should be that. But if it's a mild form or a moderate form, then that is something that may not require a follow-up to see the dentist. But if it's something more severe, and a lot of what's listed here would be things that are potentially debilitating in the future. So the severity, again, should be fundamentally based upon the professional discretion of what would be recommended. But these severities that we see here, I mean, something like cleft and lip palate, you know, these are things that should.
I totally get cleft.
Right.
But I do want to remember that we don't have a good way to get kids to an orthodontist.
Following up on Kathleen's, because a few years ago they didn't have the orthodontist even on the list, and so then we would put it as follow up, and then we got a lot of feedback from parents and case managers saying, you know, we get them to a dentist, but then that's kind of where it stops because the dentist can't help them unless they go to an orthodontist, which the Denti-Cal doesn't cover. So then it became this, then we just didn't know what to do as the screeners. So then they had put this orthodontic work recommended as the one, so then the parent and the kid is aware, but there's not much, at least, is that?
Yeah,
I think
that's my-
what we ended up
yeah.
having on our end. So the ectopic eruption then just becomes a completely different category than an orthodontist, at least in my opinion. But I think that's when we changed the screening form a little bit too.
Okay.
So I don't know if you have any other better help from there.
I think Sunny was going to say
So I was
something.
just going to piggyback up what Dr. Bejoy is saying, because that's totally correct. So we were at, it was the DCP site. We had a lot of kids with crowding. So the case manager sent them out, and then they basically came back, and the dentist is like, we're not going to take care of it because we don't get paid for it. So I think if something is, if it's an orthodontic issue, you would have to go to your pediatrician. Your pediatrician has to write that it's medically necessary. And then if it's medically necessary, then Denti-Cal is going to pay for it.
So, yeah.
So yeah, for us to put that on, it's hard, right? So we also have to remember that the reason why we're going through this is because the case managers, all they're getting is this sheet. And that's all that they have, and that's why we're talking about like really using that note section, because you're going to give them the most information that they could have that they can explain to the parent. So a lot of our parents, English is not their first language. And so we're also like, they don't understand everything that's happening, everything that we're telling them. They can't necessarily read the document. And so we're also coaching them in what to say when they go. So say you did have something that was significant, right? Like a cleft palate or something like that. Then in the notes you could write that. And then the case managers could say, you may go, because we're also going to have the case managers watch this as well. So then they can communicate and say, Mrs. Ochoa, you may go into the dentist, this is what they tell you, but also take this to your pediatrician and get your pediatrician's feedback. So that also could happen in this process.
So I understand what everyone's saying. Having worked with orthodontists who practice Denti-Cal for about 5 years, these 5 things are things they look at that are basically almost automatic qualifications for the HLD score of Denti-Cal. And maybe we can circulate something. Yeah, go ahead.
Yeah, so I think also what's happening is that within our clinic system, kids are not necessarily getting referred to an orthodontist. So they're stopping at the dentist, and the dentist is saying, I'm not going to refer you out because you're a medical.
Right.
Right, that's happening.
Manu, it's tough. I mean, it's always how many kids can we help with the resources we have. And so getting into these cases maybe goes beyond our
I understand.
abilities, is the worry.
Okay, okay.
You know, unless there's a note that clearly says this is a case that the dentist should be able to receive or to get Dental to accept,
Okay.
that really helps the case manager say, okay, then I can push it with the family.
Okay, I understand.
Does that make-
Yeah, it does. It makes sense.
Because
Well,
you probably do it, but not.
So Dr. Bindu, we can honestly send a case to his office. He has it set up where our kids are seen in his office within 48 hours. But he's the exception. He's the exception, honestly, to the rule. We have this beautiful escalation process, but then we have other clinics where Kathleen's calling CEOs in LA to get it. Like, it's literally like that. Because we're not getting, kids are not being seen. Kids are coming in, you guys see them with those infections, and they're waiting 2 and 3 weeks out. And what happened is, we had a meeting with Manu, and he was like, let me deal with this. And so he's created a referral system for us to escalate. And so honestly, so many of our kids right now are being seen by him individually because he's willing to take that on. But he's the exception kind of with the rule here.
Just a quick question. So we have 2 Western dentals that we are referring to, and they have an orthodontist coming in and we take that.
Until they're 21 years. So when they start, it's like until they finish the thing, the course, it should be 21 years. So if like we are screening somewhere like 14, 15 years, so they can be taken. And the only criteria is that the whole treatment has to be completed before they turn 21. So if someone is like starting at 17, it's fine. But I had a suggestion.
No, but that's helpful for us to know, because we don't ask that. When, like, we check those once a quarter to make sure they're still taking patients. And we should put that on there, but then you all have to be comfortable that we're sending them to Western Dental for orthodontia work.
Yes. I mean,
You know, so.
sometimes
Because
it's better
if
than
you're
nothing.
in-house, then right, I'm just referring you to my
It's
coworker.
better than nothing, you know. Sometimes it's. I had a suggestion. I just saw like in Na's slide that space maintainer was in 1E. Space maintenance is something that a general dentist can do, and it can prevent future orthodontic problems. If we put it in 2E, I mean, usually I put in my notes, space maintenance, because that's very important. It prevents any future orthodontic problems, and particularly we know that these kids can avail to orthodontic problems. If you put space maintenance in 2E, they can simply go to a general dentist, they will take a mold, and they'll put a space maintainer, no problem later on.
Or even chair side.
Chair side is very, very simple,
Yeah.
and it's like something that will prevent a future
Even just
orthodontic
a
problem.
unilateral space maintainer, they just
Right.
cement it.
It's, so we're doing vision, dental, and hearing. And with the referral rate, we started at 25%. We're now up to 31% with not necessarily any more dollars. So you really have to decide on there, look, I'm adding this, and I know a case manager's gonna have to do holist follow-up. Because I will tell you, on cases for dental, it's not like glasses, get them in the glasses, you're done. It's getting them in for cleaning and x-ray. It's getting them back in for the cavity filling, and that can be, we're up to 3 to 4 visits before we close that case. So it's just, I get spacing. I mean, I do get it, but I also get that we have kids that you're screening that are in pain
Right.
and infections. So I think you have to kind of, I mean,
It's triage. When you come in, it's like in a hospital triage. You have to see
Yeah.
the worst case and they go first, and that's how it is.
yeah, and my husband says, I know, you never give up on any kid. I get it, but on the other hand, our funders are, like First Five, starting to give us 2.5% less a year, yet expect us to do more work with it. So it's kind of questionable how many would get that as a 2 if you put in, that the dentist should just put in spacers. Would it be, I mean, I don't know what effect it would be on our overall percentage.
I don't know.
It's a shame.
Can you guys do this, or are the spacers done the same day? Does the child come back the next week, or no?
It's like two visits.
Well, it depends. If you put a bilateral space maintainer, you have to send it to the lab. So you have to take an impression, it takes 2 weeks, and then you cement it. If you do a chair side, just a unilateral space maintainer, you can do that right at the chair, make it, it comes in the kit, and you cement it.
But not everyone does that. Not all general dentists do this.
Yeah,
Exactly.
I'm just trying to understand like the timeline.
It's a couple weeks.
So,
A couple of weeks too.
2 sessions.
It's 2 visits.
Two visits for a bilateral,
2
and then if
weeks
they
around.
do a chair side, then it's at the same day. So there's 2 different kinds, depending on what they do.
Perfect. That's really helpful. Thank you.
Well, the other idea is if they're already going to be a 2, it doesn't hurt to write that in the box so that we can say, look, you're already going in. Make sure you ask the dentist for this as well.
That's a
Good.
great idea.
That's a good idea, yeah.
And then we at least catch those
Yeah.
kids. And then we gotta kind of hope, well, as we get better, I mean, less families that have the 2s and 3s, we'll be able to work on the 1s, but we have to somewhat hope that the parents that are 0s and 1s would read it and use it on their own. So, does that kind of work? So maybe change this a little?
Yeah, we'll change it and
Is that
resend
okay
it.
with you, Manu? And-
That is fine.
I know you
I
don't
do
like
like,
it.
I do like, I do like Dr. Kosler's suggestion. Maybe looking at referring to Western Dental Orthodontia specifically for that, but I think that can be reevaluated at another point. But we would change the slide appropriately because there are a lot of other bigger ticket issues that are there, and we're trying to prevent the infection. We're trying to prevent the pain, the swelling, potential trauma that's occurred, and those are bigger issues at hand right now than something that already what we're placing as routine would be followed up with the parent when they go see the dentist for routine dental care.
So we need to capture the 2 that,
Yeah, so we're gonna revise the dental resource page and ask those questions to see if they have.
So off the current list, the 2 things that just got brought up regarding is there an ortho in your office, taking Denti-Cal, and then the spacers. And that we can ask those 2 questions. And then indicate that on the results or our resource page.
Okay, well, it's good that we're having these discussions. This is likely one of the chief variabilities in terms of why there's a spread of the standard deviation that we have. So it's good that we're all in the same room talking about it. So let's move forward then.
so
Yeah.
Manu, let me ask you though on that, like you don't have an orthodontist in your office.
No.
Do you send them to Western Dental then for?
We send them to a private orthodontist, father and son practice, who we've been referring to probably for the last 20 to 25 years. So they do take on cases that are more severe, and they do offer much more limited payment options, or a wider variety for our patients specifically. Certain cases we have sent to Western Dental for orthodontia, but we always start with sending it to that practice, and then if there's any other concern and they come back to me or come back to us, then we then refer out to Western Dental. Yeah. But again, specifically for orthodontia, but comprehensive care we provide. Yeah. Okay, great. So continuing, yeah? Okay, so continuing now with number 3, and again recalling the previous breakdown. Whenever we were working with urgent, we're looking at a follow-up with a coordinator within 2 weeks. When we're looking at emergent, we're looking at a follow-up with a care coordinator within 1 week. So we have 3 things listed here: infection, pain, and severe cavities. Moving forward to the next slide. This is an example of an infection. It's usually an abscess with or without a fistula. Can be in the gums or the soft tissue. Similar to other ways that we've just explained to describe, to make notes within the comment box, is this would be an example of that, where we have the chief concern, we have the history and the objective finding, and then to follow up with a dentist because the tooth or the patient is at high risk for dental infection. Moving forward to the next one, we have pain. Something like this, when a child has pain, it's likely that there's other things that are going to be marked with pain. There could be infection, there could be severe cavities as well. In this particular case, only letter B was checked. And of course, as it is, anytime a child is having pain, and then placing in the comment box the similar concept of providing the chief concern, the history, and any objective findings that's placed. And this does tend to help with the care coordinators in communicating to the parents to get motivate the parents or the guardians to then take their child in to see the dentist and then close the case on the referral.
So, I'm sorry, Manil,
Yeah.
I need to see this beforehand, so can you go back one?
Yes, of course.
I'm a little concerned that we go to the schools that need us the worst. And if you look at our data, roughly 50% of the parents don't speak English at home, so I'm a little worried about words like gingival.
Right, gum abscess. So we say gum?
Well,
A gum abscess.
Well, the thought of that was from the previous meeting with the case managers. They wanted to have dental terminology on there because they thought it would strengthen this form. And then we can put in layman's term gingival abscess or parentheses gum infection for them as well. Is that
Yes, we really
Yes.
like that. We really like that because it does strengthen the results form, so the parents will take this result form a lot more seriously. We'll take it to the dentist and share it with them and say, my child received a screening, this is what it says. I received a call, and that's why us case managers are here for. We'll call the parents and kind of explain to them in their own language and in a level that they will understand.
So you're giving the case managers a definition page anyway, right? So,
yeah.
because this is a lot kind of to write during the minute and a half screening also.
It is a lot. You guys do a lot.
We wanted quality over.
Can I maybe a suggestion? Because I mean that is just something that as a practitioner on a daily basis, that's how I dictate my notes too. But since we're in a more like we want to make everything uniform, would it be possible to create like a vocabulary list so then when we're at our screening we can just say like, okay, just put abscess, or just put pain or foul odor or something like that, so then that way everybody's going by the same list.
Yeah, it's a great idea.
Maria says though they like it that detailed because it helps the family understand that you're the dentist sharing it with another dentist. But those are the scripts in essence, right?
Right, and we are signing it with our own, signature, and so it should come from like a dentist point of view.
But you're saying like scripts.
Not
Almost.
scripts, but like vocabularies, so we're not saying like gum abscess versus gum boil, just like an abscess is an abscess,
Okay.
Just an idea.
I think that would also make it easier for case managers if we see the same vocabulary words every time. It becomes easier for us to understand and for us to explain it to the parents. So I think that would work for us as well.
Yeah, we're creating that dental terminology in the script for you guys. So, yeah, we'll all use the same scripting.
Yeah, so after this, to what Dr. Carey had mentioned, was that she's working with NA to put together a common dental terminology, which then will be used to not only educate the case managers when they're going through, but then also we'll share it with the providers as well to make sure that everyone's kind of speaking the same language. Okay. To continue then?
Yes.
Yeah? Okay. So the second, as what we had walked through this regarding pain, and anytime the child reports pain, we have a comment box. We do want to be a little bit more descriptive as per what was talked about and with the feedback we'd received from the case managers. The content of this may change while we do the common dental terminology and what is going to be utilized for that communication, but the idea is that whenever the child has pain, make sure the tooth is circled or the area of the mouth on the odontogram is circled, and something is noted within the comment box to then educate the guardian and the parent or educate the case managers. And then the last thing, severe cavities. This is just kind of a refresher. Dr. Carey had already discussed this in detail, but we do want to focus on depth as opposed to number of surfaces. Anything that is close to the pulp or appears to already be infecting the pulp, then we want to note that into an emergent and then make sure that it's noted in the comment box as well, in addition to the odontogram. The last thing to discuss is the sealant measure. The Department of Public Health, to what Kathleen had talked about, where a lot of this data that's being collected is being shared at the county level and at the state level. They've come back and they've requested to document when a sealant has been placed or when a sealant hasn't been placed. And this is just to go into a little bit greater detail on it. So if there are sealants, then in the comment box, place sealants, yes. If there are no sealant or none present, then write sealant equals no, or if it's not indicated. So for example, with the idea of a number 19 permanent molar that's not present and there are no other permanent molars in the child's mouth, then just write not applicable when it's not indicated. Okay, and that wraps up what we have for the clinical guideline discussion that we have, and then also the sealant measure.
So this is the sealant we're talking about? Yes, but we're gonna ask you to put in the comments, maybe we just put S equals NY or NA. The state really wants to know have sealants or not, and because we do those ages that are kind of in between, it's hard to give them that date. Even if you said yes, it would be either, it's easier in the box to just also say S equals Y, or, you know, just somehow. We're gonna add that.
Same question about
Maybe.
If it's already restored molar, would that go under NA?
That's a very good question, but that would go under NA, yeah.
Okay.
Do we specify teeth in terms of like which have sealant?
No, it's either they're there or they're not there.
That's all they want. We ask that.
And sometimes sealants are clear, they don't have color, and you need Explorer to actually say for sealant.
Right, so then if you can't visually see it, then it would be no, right? If you can visually see it and it's present, then it would be yes.
Wait, so is the point of the sealants comments to correlate sealants and carry?
Yeah, that was something that was discussed about, but either way, right now they're asking us to collect that information.
We're not sure why they would. I mean, they would also like a lot more on fluoride data, but this they specifically asked that way.
These are something that we are very important here.
Yeah.
Fluoride and this thing. I have a list of the zip codes, the zip codes that has fluoridated water. In that case, we are not supposed to give or supplement fluoride. So that helps too. If we see a lot of decay going on, we can always ask the patient, and that also helps a lot.
You know, there still are a lot of areas in this county that are not fluoridated because it's based on groundwater, right? So you were saying zip code.
Yeah.
And then there is a worry that the kids aren't getting a lot of water out of the taps anyway.
Right, so they
So-
could be fluoridated, but they're not drinking the tap water.
Yeah.
Yeah.
Yes.
So the county has in their written requirements at the county clinics, the pediatricians are to do fluoride for all well-care visits up to the age of 5. Now, that's new. But according to the information I have for Medi-Cal, you can have fluoride varnish 3 times a year. If needed. And I just don't have, I mean, my area, I'm in Saratoga, we don't have fluoride in the water. But most of us have toothbrush, toothpaste. Yeah. And everybody, and I mean, they do get a toothpaste from us, but, yeah. I don't think it hurts to circle that all the time.
I have a question, just a general question about the organization. I mean, when the case managers are speaking to parents, is there like a preventative aspect to that conversation?
There, I think Maria and Erica are going to talk some.
Oh, okay.
And maybe we should send out what's in the 10 steps now. So we have added 10 steps. We think we might be getting into dental training too for parents. But we haven't gotten as far as we'd like on that.
Are those like taken from the same pool of patients that we see in the screenings, or are they just like how does
Yeah,
that?
they're pretty, I mean, they're not exactly, but they're pretty similar.
Because the life from the teacher.
Yeah.
Okay.
Okay, so we are program coordinators. My name is Erica Ambries, and this is Maria Padilla. So as we mentioned earlier, Maria has been here for almost 4 years. I've been here for 2.5 years, and what we do here is we are program coordinators for the vision, dental, hearing programs, and Maria for the COPE program, and me for the Baby Gateway program. The dental program is really important. It's one of our biggest, I would say, challenging program, because it's a challenge to get kids into the dentist. There's not a lot of knowledge, and there's not as much emphasis as dental care compared to medical care, as you probably already know. So we're going to start off with Maria. She's going to talk about the process of what usually happens and how we get these out of range cases.
So good evening, everyone. So we're going to go ahead and start by explaining kind of how the cases get to the case management team. So first, the screening happens, and then this is for a non-urgent case. Then from the screening department, they come back, and then that case goes to data. Once data enters the child's information into Salesforce, the information goes to our program manager, and she assigns the cases to the case manager. So the process in all for just a regular case, it takes about 2 weeks now. And like I said, this is for an urgent case. So what we do is for the first phone call, we try to explain to the parents that the screening was done. We emphasize that the screening was conducted by a licensed dentist. That's the first thing that we explain to the parents. Second, we explain the results and kind of what the results mean and what the recommendations are. 3, we discuss the resources with the parents. So a lot of our parents have language barriers, transportation barriers, health insurance barriers. So the first call is really important, because that's where we establish kind of what is the nearest dental office closest to them that speaks their language, that takes their insurance, and we also assist with transportation issues. So the first call, usually most of our parents are receptive, but we do have those parents where they're really angry that we're calling, and they're really upset that there's a potential issue with their child. So we come across those parents as well. So after we provide them with the resources, a lot of parents like texting these days. So we will usually send them a text message of the dental resource page that has all the dental offices in their area. Or some parents say, I really want to go to this office that's closest to my home that you mentioned to me. So then we send them, just a couple of options for the parents. We never tell the parents we never tell them you have to go to this office versus this office. That's normally up to them. Sometimes they do tell us they only can go on weekends, so we'll give them the list of the offices that are open only on the weekends. So after this, the first phone call, the second phone call, what we do is we follow up in about 2 weeks, and we ask them if they were able to get an appointment. Most of the parents will tell us yes, they provided an appointment. Our appointment is in 2 weeks. If the appointment is more than 21 days ahead of time, Then we have an in-house process where we kind of escalate the case to Kathleen, and we try to find out, is it the parent that's choosing to not be seen in 3 weeks, or is it the office that's booked out? So we try to assist the parents and, make sure that this appointment works for them. There are some offices where they will do the work really fast. They'll get the child will get the exam and cleaning in 2 weeks, treatment in 2 weeks. That's normally what we like to see, but that's not how it happens. Some offices, the child will get the exam 1 week, cleaning 3 weeks, treatment 1 month. So that's kind of how some cases go. The third phone call, we usually by the third phone call, most of our kids receive some type of treatment. So this is kind of where the parents will tell us, my child received an exam and a cleaning, and they're going to receive treatment in a month. So what we do is we'll keep the case open until, if the child needs fillings, then we'll keep the case open until the child receives the complete treatment. Especially if it's an urgent case, we follow up with it until the child receives all the treatment that's necessary. A lot of parents really like this because they feel that we are there to support them in anything that they need. So by the end of the third phone call, we are best friends with the parents.
And this is just an ideal situation. We wrote down first call, second call, third call. It's not always like that. Like Maria said, there's a lot of obstacles that families face. So we're there. We're speaking with the family maybe sometimes up to 3 months. That's ideal, right? We would love to have a case open for no longer than 3 months, but sometimes we're with them up to 6 months, depending on the severity of the case. And we'll keep calling, texting, email, until we get the kid into treatment. So the way we do communicate with our families is by phone call, text, email, fax, or whatever they prefer. A lot of the times families do like texting, and we do have the ability to send a picture text message of the results form in case they didn't get it. We also text them resources, or if they prefer email. There have been some parents who have asked us to fax over the results form to their dentist, so we are open to that as well. And I think we've had some actual doctors contact us asking us about our results form. So we have been able to relay your information to them. Some difficulties that families face, like I said, we might have a case open for 3 months to 6 months. Some of these difficulties, why the kids are not receiving the treatment that they need, is because results. So the results form, for example, when we give the results forms to the parents, they may not speak English or not be able to read it or understand the terminology, and that's why we contact families. We're there to discuss those results with them. Second one is making parents, there's a lot of parents who don't feel the urgency of taking their kids to the dentist. They may not understand why it's important. A lot of families will say, well, my child is not complaining of pain, so I'm not going to take them in. There's a lot of the times we've seen a results form where a kid has an infection, and they will ask the child on the phone, Mijo, does your mouth hurt? And I hear the little kid going, no, and they'll tell us straight up, no, we're not taking them to the dentist because he feels no pain. So, and a lot of the times, I had a case where I was speaking with mom for a very, very long time. I was trying to convince her about the importance of taking the child into the dentist. He was 13 years old in middle school. He had about 5 to 6 cavities, and I couldn't understand, why is mom not taking this kid into the dentist? Turns out she eventually, maybe at the 5th phone call, once we became finally best friends, she told me, Erica, I've never been to the dentist. She grew up in a different country. I think it was one of the southern countries. I can't remember. She said, we just came to the United States. I've never been to the dentist. I have no dental issues. I have high school kids who have no dental issues at all, and they've never been to the dentist. To me, that was a shocker. I'm like, oh, wow, your child, you've never been to the dentist, but you also grew up in a different country where you're eating more organic foods. Here in the United States, you're drinking a lot more soda, eating a lot more chips, And that's where the education came. She was so surprised to find out when she finally took her middle school kid in, he had a lot of issues. She was so surprised and so shocked. So that's one of the difficulties we see a lot. Another difficult issue is no insurance. A lot of the times kids won't go in because they have no insurance, and that's where one of our other another program that deals with insurances, we identify, connect them with a certified enrollment counselor and enroll them into an insurance program that they may qualify for. The majority is the Medi-Cal. Another difficulty that kids face is a lot of them do have private insurance. And as you know, private insurance only covers up to a certain amount, and if a child needs a lot of work done, it doesn't cover much, and parents will have to pay out of pocket. I don't know if this is very accurate, but from my personal experiences, a lot of the kids who grow up in the Morgan Hill area, Gilroy, those families, there's a percentage where these families do have money and they do have private insurance for their kids. Those kids are kind of hard to get in for treatment. They say, yes, we have insurance, we know the problem, but I just can't afford for it. I can't afford the treatment. So a lot of those are really difficult. Also, parent availability. A lot of the parents in our area work full-time. A lot of them have 2 jobs, trying to, just survive, to pay for rent, pay for food, and they don't have the time to take their kids into the dentist. Another one is a lot of kids will go to the first appointment, receive the exam, and they're given a treatment plan, but parents don't follow up with the treatment plan, so the kids will never finish receiving the treatment that they need. And those are just some of the difficulties that we have came across, and there's a lot of other, but those are the big major ones. And now Maria's going to be talking about what happens when we come across a case that needs to be escalated as soon as possible. So a lot of the times this will be a child has 5 cavities and an infection and who knows what else. Go ahead, Maria.
So now I'm going to go ahead and speak to you guys about what happens when there's an urgent case, or when you guys find someone that has like a severe infection. So what happens is that the screener will send an email, and this email will be sent to upper management, which is our manager, Erica Gonzalez, Mark, and Sunny. And then Erica Gonzalez, she will assign one of us, a case manager, this case to work on. So this case manager, for example, myself, I would contact the family right away. That takes priority over anything else. As soon as I get that email, I get the child's information, I will try to contact the parent right away. I would usually we are able to get in contact with the parents, so that's always good. We would immediately start calling some of our partners, and today I'm going to talk about the Indian Health Center. We have like Sunny said, an awesome partnership with them. So what I would do is we call the parents, and with the parents' permission, we do a 3-way phone call to one of the care coordinators, Leslie from the Indian Health Center. Her and I, we work together with this process. Is I would call her and I kind of explain what the process is, or kind of what it was found, and they're very accommodating. Usually our kids are seeing within the day or the next day. It's really up to the parents whenever the parent's available. So that process has worked out really, really well for us. After we schedule an appointment for the child, what I will do is I will complete one of these forms, and it's kind of a form that they created for us where I can write down a little bit about more information about the case after I talk to the parent. And then what I will do is I will attach this form to an email, secured email, back to Indian Health Center, or I'll go ahead and fax them the information. What we try to have on hand is I try to have the parent be ready with like the Medi-Cal card, and I usually ask those questions before I make the initial phone call, so that also the clinic can get the information that they need right away to schedule the appointment. After the appointment is made, for example, if the child has an appointment on Wednesday, we follow up the very same day, just to see if the child did receive the services that they need, and to talk to the parents a little bit about how the appointment went, and make sure that the parents have a follow-up appointment scheduled. Like Erica said, sometimes parents don't follow up with the appointment, so we talk to them about the importance of following up and going to their very next appointment to complete the treatment that the child needs. And that kind of completes our presentation. Yeah.
So we're talking about escalation, and that it's part of emergency, right?
Yes.
So us as dentists, during the screening, we feel like a child, we were talking about dental neglect or whatnot, we tell the dental screener right away, verbally, okay, and then it gets escalated.
Yeah. So, and that's another thing that we see, and why that's why this training is so important, because sometimes we see some kids escalated really fast, and then sometimes we would get our regular caseload and we would find a child that I thought, oh, this one, I think we should have called this kid three weeks ago. And also because we advocate for the child, and for some of us that are mothers, like we take the cases really seriously. And sometimes when we have cases like this, I don't want to go home until I make sure that I talk to the parent, that the parents know that we have a scheduled appointment. So that's why the dental 3 are really important. And like Dr. Carey said, if you guys have something that just looks very urgent, an infection, go ahead and talk to the screener. The screener will come back. It will be escalated, and we would probably have the child in a dental chair, the next day or the very same day, depending on the parent's availability as well. So we take those cases seriously.
And this really started, I don't know who it was that's probably here, but somebody had a case where it was severe neglect along the lines of something that should have gone to CPS. And so through this process and what happens in terms of the escalation is I'm part of that plan, because I'm then contacting the school. So I'm contacting the school district, and there was a case that whoever that dentist was said that this was so severe that she would call Child Protective Services, or he would call Child Protective Services, and it took us, it took our case managers, it took a student services director of a entire district, it took a community liaison and a principal to talk to this mom to convince them that they actually needed to go in. And then it took Kathleen to escalate these appointments. And that's really where this came from, is that then as we started having these conversations with the screeners, that it was like, oh no, this dentist said this and this dentist said this. And really where we're seeing that there are these issues that really do need to be addressed. And then there's been conversations that have happened along the way too. As part of our case management, they go back and they talk to the parents. How did you like this service? And where kids have said, well, I know my mom is so busy, I don't tell her that my teeth hurt. And that's really the reality of it, right? When Erica said, oh, the mom asks the kid's like, no, it's fine. There's probably a million things happening in that household. And even if you're 8, you know to say it's fine. And the reality is it's not. So that's why it really is important, what you guys are doing, and really being able to identify those cases that we need to take special attention to. And we're really lucky that we have partners like Manu that are willing to say, okay, we're going to give you guys these appointments today, tomorrow, and the next day. And it's us working all together as a community, really, because we're working so much with the school to say, come on, we can get your kid in here, just get the afternoon off.
And you guys are doing such an amazing job just this past year with Mark's coordination. You guys have screened so many kids, and sometimes I don't know who it was who screened that child that was child neglect. It was you? Oh, okay.
Therese was the screener.
Therese was the screener, but it was this dentist, right?
Yeah.
So if you would not have said anything to the screener, that child would have gotten lost with all those thousands of other kids that we had screened that year, and we probably wouldn't have contacted mom until 2-3 weeks later, and we would not have known that it's a possible child neglect. We could have called mom first time, we'll call mom again following 2 weeks. No, I haven't scheduled the appointment. Okay, well, I'll call you again in another week to make sure you scheduled it. Called again. Now 2 months have passed by. Mom still hasn't scheduled the appointment. Then we start to realize something's going on here. If you guys notice anything, that's why it's important to tell the screener that, there might be something happening here where we could get right on it real quick. it's forwarded to our managers. Managers make sure it's emailed to our data to be entered right away. And then also at the same time, we don't wait for data to enter it on our system. A case manager will be assigned to the case and follow with the family as soon as possible and try to coordinate with everybody. Services.
What might be nice, and maybe not, you could help with this, is reading the testimonials, just really make it easier to do this every day. Some of the parents are just so grateful because they say, I'm trying to go to school, I'm working, and thank you for just sticking with it, or thank you for getting anesthesia for the $10,000 bill I would have had for my job. It's maybe we could start doing that every once in a while. I try and read them Sunday nights because it gets me ready for Monday. Inspiration. They make me, a lot of them make me cry.
And what Maria and Erica were talking about in terms of their caseload, on a given week they can have anywhere from 40 to 100 brand new cases a week. They're carrying about 600 to 1,000 cases a year. So when it can get lost in the shuffle, it can get lost in the shuffle.
That's true.
Yeah. Do you guys have any questions about case management, resources?
It was so nice to attend this. We don't know what's going on.
Yeah.
It's like really,
It's a lot of challenges.
Well, it didn't get presented, but there's some pretty good data. We should probably send out, I know you guys aren't dashboards, but I'm dashboards, just showing how the data's changed over years and looking at different age groups. And for example, this has, the last 3 years, and 3 to 5 year olds, 34% this year got a referral. 3 to 5 year olds. And 6 to 8 year olds, 35%. 9 to 13 year olds, 28%. 14 to 18, 22%. So the group that got the most was the 3 to 5 and the 6 to 8, which is like scares me to death because it's like a tsunami that's getting worse, not better. But